Welcome back to another edition of the Heart to Heart podcast. And my guest today is returning guest, Dr. Ira Price. He is a sports medicine physician. He's an emergency physician. He's been on the show 3 times before. So welcome back, brother.
Thank you, my friend. Glad to be here as usual. I've got the eye. Oh, the eye behind. Wow, that's so weird. It's the opposite side. I've got the eye staring at me.
Well, I got the eye actually staring straight at me
Oh,
there too.
that's true.
I can actually see it. So,
How you feeling?
I'm feeling good. This is actually, I think, my first podcast I've recorded on a Saturday. So I like doing this so far.
Well,
It's good.
some of us have to work on weekdays.
Yeah,
I'm
yeah.
just, I've been working a lot of nights lately, so I haven't had the chance. During the day, I'm basically a zombie, and then I go back into work at night. So it's been hard. This is probably the first day this week I've had the opportunity to just do nothing.
Well, you need those opportunities. We all need time to rest, or else we burn out, right? So,
Is Starbucks
so,
going to get
so
mad if
important.
I drink on camera?
I don't think so. I don't think so. You can't
All
really
right.
avoid product placement with Starbucks these days. So,
Still,
anyway,
yeah, man. How are you doing?
good. But since I've chatted with you, I think there's been
Yeah.
two kind of major things that have come out. The big one, I think, was with Doug Ford saying a few weeks ago that and I mean, I don't even understand all of it. So hopefully you can kind of share some knowledge on that. But yeah, so he's basically come out and said that there's more opportunity for public health care. My kind of view on that has always been like there should be two systems, if especially if the private system's not going to affect the public system. And my view on that has always kind of been like, well, if there's less people in the public system, wouldn't that even make the public system better? But then I guess the issue with that is staffing. If a lot of the nurses and staff, quit the public system and go to the private, is it going to affect the, public system? So what do you make
Well,
of all of it?
well, it's interesting. I mean, there are some two-tiered systems or two parallel systems that exist right now within the world. We look at Australia. Australia does pretty good with it. They have a a copay and a private system and a public system. And the problem is we're very North American centric here. So when we think of a private system, we think about the private system of the United States, which, by the way, spends more on public health care than we do in Canada.
Interesting.
And, yeah,
Is
and
that is that like is that like per person, or do you
yeah,
mean
like their GDP based on public healthcare is like twice as much as we pay.
really?
They have public system. It's just that it's hard to get. And there, one of their major issues is finding good providers that are still in the public system. But they have a public system. They've always had Medicare. And they spend more on Medicare than we do on healthcare. So you always have access. It's just hard to it's finding the right services are more difficult. They've also done studies in the US, and this is, I think, where a lot of the issues come from. Back probably about 15 years ago, we did a lot of feasibility studies and productivity studies in Canada's system versus the United States in a for-profit model versus a not-for-profit model. First of all, I want to start off by saying I'm an emerge doc and a coroner and sports guy. I'm not a public health guy. Like I did a bunch of administrative stuff early on in my career just to get a better understanding of it. But I mean, this is by no means my expertise. I
Yeah.
just happen to, I happen to be very like opinionated dude, like you. So, I don't want to come across as an expert in any way. This is just a bunch of docs sitting here chatting about, what we think of and caring citizens who like really just want to do good for for the public and also for medicine while trying to earn a living, which there's nothing wrong with.
Yeah, I mean, I
uh
I don't have all the solutions. I don't think we're going to find the solutions today, but I think
yeah,
it's good to chat about it so that people
yeah.
know what's
So that's
coming.
my disclaimer. So the studies that were back to the studies that were done in on a for-profit versus a not-for-profit system, which, by the way, so just to clarify, currently Canada's system is publicly funded and privately operated, right? So that's how the system works currently, and we actually also have these independent health facilities that we've had for a very long time in IHF Fs that have been around for like 20 years. We've had private clinics for a long time. You just have to be licensed, and it's hard to get these licenses. And Canada hasn't, or Ontario in particular, hasn't issued any new licenses to any of these facilities in over a decade, which has been the major problem. So we have that system here. It's just not a very robust system, and it's hard to access. So in the United States, when they did these studies, it always showed that there was a higher rate of death in a private system than in a public system. So the conclusions always were, well, in a private system, people are, being pushed through too quickly. Their care may be okay, but the physicians are okay, are good, but at the same time, their goal is to make money, not patient care. So we have to be a public system. These were the early days, studies in the early days.
What time frame are these studies from?
About 15 years ago.
About 15 years ago. And they
Yeah.
showed basically that if you're in the if you're in the private system, you have basically an increased risk of all-cause mortality.
That's
versus
right.
The public system.
That's right. Yeah. In a public system, the goal wasn't to make money. The goal was more patient focused than it was in a private system.
Okay.
So that again pushed Canada and Canadians towards, let's stay in the public sector. We also have the whole idea in Canada, which is the basis of our healthcare system, of universality. So healthcare for all, right? Which is really important. We have 4 pillars of medicine, one of them being, universality, and that's super important. We don't want to lose that, and I agree. We should never lose that. The major and then to acknowledge people's concerns right off the bat, like you rightfully mentioned, is, well, one is a staffing issue, where where are you going to, if you take all the staff out of the public sector, because they're going to get paid better in the private sector somehow, which, by the way, is not usually the case for anybody outside of maybe the treating physician, because now overhead is higher, everything sort of goes up, and it's just less stressful usually in the private sector than it is in the public sector, but pay is usually better in the public sector because it's government funded, although this still will be government funded. We'll come back to that. And then, so you're worried about staffing and taking away staff, both physicians and nurses, out of the public sector, bringing them to the private sector. And then at the same time, you're also worried about how is patient care going to be handled. So I think what we have to do is look at what's been happening with our healthcare system over the last decade to begin with. Have we been able to provide appropriate care and timely care in Canada? And let's talk about Ontario, because that's where Bill 60 is, appropriately within the last decade anyway? And if the answer is no, we clearly need change. And I think the answer is no. We haven't, we have backups on backups of surgeries, and not just surgery. Like, we're talking critical things like that, cardiac surgery that went on waiting lists. And and we're also talking about, so that's like mortality stuff. I was going to swear I was going to say shit, so I did it, but I didn't. But then I guess I just did. So we have mortality stuff, like cardiac surgeries, but then on the other hand, we have morbidity things like hip and knee replacements and cataracts. If you can't see, the reason why cataract get these, so we always say, oh fuck, these cataract folks make so much money for doing cataracts, they're so quick and all this stuff. But imagine you don't see and then you see, it's a big deal. It's a huge deal. Yeah. So
this probably plays the risk in prevention of falls in the elderly as well, because
for sure does.
As we know, falling down when you're elderly is really bad, especially if you fall and you break your hip. Your chances of dying are,
you're done
dramatically,
well, that happened to my grandmother. Actually, funny enough, not funny, I mean, it's sad, my grandmother, when she passed away, but she was in pretty good health, probably early 90s, broke her wrist after falls and a fracture in an elderly patient. Mortality is it's all it takes, because as soon as you can't move, you're done.
You can't brace yourself. And I think, not to get off topic, I think that's also too the reason why retaining muscle mass is so important when you're in your 70s and 80s, because if you can break a fall, if you can grab the rail, or if you can, even just, outstretch your hand, or, just to break a fall in some way, like you're really going to, reduce your risk of obviously of having a fracture, but also too of just overall mortality, because the mortality rate once you get a fracture is just skyrockets once you're above the age of 65.
I would love to be talking about muscle mass. I totally agree with you. Maintaining muscle mass is like the number one predictor of mortality in the elderly.
Yeah.
Mobility,
Yeah.
you got to be able to
Yeah.
move.
Yeah. They need to keep their protein intake high. But anyways, we're getting a
Okay,
little bit off
right.
topic
Okay,
here. Yeah.
so back to these centers. So for the last, so these are the concerns of Canadians, and rightfully so. They should be the concerns of all citizens in any society that believe in the advancement or in the protection of society in general. You want healthcare. So then the question is healthcare being provided okay? Like, is it satisfactory as it is? Instead of saying, poor, good, excellent, outstanding, just say satisfactory, unsatisfactory. And we're definitely unsatisfactory, right? We have wait lists that go on forever. We have emergency room visits that are 12 hours long, with waiting times are 12 hours long, 8 months on average to get in to see a doctor for your hip or your knee, sometimes even more. 2 years you can wait for a knee replacement. Like, these things are just unacceptable.
And people have
Now,
to wait a lot of times like 2 or 3 weeks just to get into their family doctor, or
I
more.
mean, I wish 2 or 3 weeks, two or
Yeah.
three weeks, our departments would probably be half full. Like, yeah, I just saw this thing where you have a broken arm, go to urgent care. You have like obstruction, come to emerge. But like, people are coming to emerge for like runny noses,
Yeah. They
like
should be going
because
to walk-in clinics. We should make a big emphasis on walk-in clinics for things like that.
yeah.
Yeah.
Oh, like there's, I mean, you know how that gets me going when we talk about family
And
docs seeing their patients.
also too, again, I don't want to get off topic with the walk-in clinics. Like walk-in clinics, a lot of them are open in the evening, but a lot of them are actually not. And the other thing is that none of them, from my knowledge, are open overnight, right? Like you're not
No,
going to have a walk-in clinic where you start your shift at like 10 p.m. and end at 4 a.m. And I mean, if there was, like, and the reason why there isn't is because there wouldn't be enough patients for the doc to see for it to make his time sort of
it
worthwhile.
depends
That's,
where.
yeah. I mean, yeah, you're right. I mean, if you just had like one, maybe that could be some type of solution. Like if you just had, one or two kind of concentrated walk-in clinics, and you said, if you go to these guys during these hours, you can, get treatment without having to come to the emergency room. I think a lot of people would appreciate that. Then you just want to make sure that people aren't going there with like, strokes and heart attacks, and you
Right.
have like
Well, I
the
mean, that's
opposite
like,
issue.
I mean, I think that would kind of be like any urgent care or any walk-in clinic. And
Yeah.
if that happens, you send them right over to the emergency department.
Yeah.
The problem, I mean, just off topic on that, is one of the major problems with that would be like, how do you fund something like that at nighttime? Right.
Yeah.
So in the hospital, like, nobody wants to work nights. I'm one of the very few docs who enjoys working nights, because there's less, all of the things, less administration, less headaches. I get to do my own procedures. A lot of the time I keep my skill up. I see a lot of patients, and then, it's just a lot more relaxing for me to work nights than it is during days when the hustle, there's like millions of
Yeah.
people around, everybody's telling you what to do. I don't do well with that.
But
So
maybe the way to get the docs to work and walk in clinics overnight
is
is
to
to
give them
incentivize
is,
them with extra
these
pay.
family docs are so incentivized already. They just need to start seeing their goddamn patients. I'm sorry, you want my opinion? That's my opinion. My
I
opinion
see
is these.
patients all the time,
You do, yes. There are very
constantly.
good family docs, but there's also family docs that work part of these integrated family health teams, FIGs and FOs and all this stuff. And these guys are working 3 days a week, 3.5 days a week, seeing 20 patients a day, and they have wait lists on wait lists to get in to see them, because there's no reason they have to see those patients. They get
Yeah.
paid whether the patient shows up or not. They're making a very, very good income, more than I'm making in the emergency department, maybe sometimes even double. Okay, so that's how and it's not because I need to get paid more or whatever. The idea is see your patients. If you actually just saw your patients, not you in particular, but if family docs would just agree to see their patients and had really good health teams, and some of them are, you could see, and they should use those ones as examples, then we wouldn't have that problem of having to wait 4 weeks, 6 weeks to get into your family doctor. Anyway,
Yeah, I
okay,
agree.
That's where I stand on the issue. Okay, back to private and public healthcare. So these are issues within the public or in society in general that I actually think are very reasonable questions. How do you provide safe access, or is there going to be a lower standard of care in the private sector or the public sector, depending on, are you pulling all the good physicians out of the private sector, taking them to the or from the public sector, taking them to the private sector? Is there going to be a higher risk of secondary outcomes, of poor outcomes, because you're just trying to wheel them through in the private sector so that you can make more money and meet your overhead? These are all questions that are very reasonable questions to ask. So what Doug Ford did, first of all, as I mentioned, they already have integrated health or independent health facilities. These independent health facilities have been working like Shouldice clinic for where you go for hernia repairs, have been working for a very long time. And there's a bunch of them. There's Medcan. There's a whole bunch of them where there is a copay, but there is a basic fee structure that's still covered by the government. The way that they plan on doing this is they're going to take these independent health facilities, which hasn't granted any new licenses in over a decade, and they're going to turn them into integrated community health service centers. Basically, it's just a new name for what already exists. It's still going to be very difficult for anybody who wants to enter into this world. They're going to have to meet a very specific criteria to get into the world. And to open these clinics. And not only are they going to they're only for very specific things like dermatology, ophthalmology for cataracts, hip, knee surgeries, and imaging. That's basically what they're thinking of. But you could go to Mississauga now, and they have a clinic where they do public and private MRIs and CTs already. Like they're just going to expand and make it more robust, the system that already exists. If it actually works. I don't even know if it's going to work. But those are the things that they're planning on integrating into the system. So they're going to expand those services. But in order to meet criteria and be able to be one of these private health systems, you're going to have to be licensed. So there's very, like the same way we have if you're a level 2 pain clinic kind of thing, you have to have an out of hospital premises evaluation and meet all this criteria. You're going to have to meet the same sort of criteria, but with different standards. You have to come up with a very good plan for staffing. So you have to explain in your business proposal to the government, in your application, you have to explain to them how you're not going to remove on a significant basis the staffing that's in the public system. So you're not going to increase the burden on the public system in your private sector, right? So for example, if surgeons are already only doing 1 day a week in the OR because that's the only time they have, in your proposal, you say they're still doing their 1 day a week there. They're just going to do 3 days a week over here, right? So you're not taking away from the public system. That has to be integrated into your plan. That's one
important.
thing that's very important. So will it alleviate the public's concern that you're going to just cause more problems in the public system by bringing these physicians over? It doesn't, but what it does do is alleviate a little bit of that stress that they've taken into account, that you can't burden the public system by moving them into the private system. So that's one thing. The second thing that they've also done in Bill 60 is they've put in or in your proposal, you also have to, or one of the mandates is that you can't refuse. So the public system, the government is still going to fund OHIP in Ontario, is still going to fund these private clinics. So you can't, let's say you need a hernia surgery or you need a cataract surgery or a knee replacement. Currently, those are insured services, right? So those insured services aren't going to come out of the patient's pocket. So when the private system, it's not like you're going to go and pay to have this done. OHIP is still going to cover the basic things. So in the private sector, the physician is still going to bill, or the clinic is still going to bill the public system, OHIP, which is basically, look at OHIP as the largest insurance company in Ontario. That's what they are, right? Like, you have Sun Life, Green Shield, all those things. OHIP is just another one. That's all it is. It's
And for
just
people who don't know what OHIP is, just
the
remind us.
Ontario plan. Look at health insurance plan. So if
Yeah.
you look at, like, right now when you get OHIP, you get a drug card, or not OHIP, when you have regular insurance,
Yeah.
like or secondary insurance for drugs and physio and all that, like Sun Life, or like insurance on your house, insurance on your car, all that kind of stuff. Those are private insurance companies. OHIP is the largest insurance company in Ontario. That's what you just look at it as an insurance company. When you understand it as a regular insurance company, it all makes more sense. That's
But
what they are. They're just publicly funded.
the one thing that I don't understand you just said though is like you said they're going to private clinics, but they're
Yes,
still going to be funded by OHIP.
that's
So
right.
so the patient doesn't pay any money to go to a private clinic.
Correct.
See, that's very, very confusing because I
It
thought
is.
that, if it was private, then you would be paying out of pocket.
No.
So is anything like, can you go to a private clinic and pay out of pocket? Like, is that even possible?
So it is possible. So if you look at somewhere like Shouldice, right, you can pay to stay there. You can pay for an upgraded service. You can pay for the extra special cataract. The government will pay for the basic stuff that's already paid for in the public system. If you want like an upgraded version of that, you can pay out of pocket for it. But
Okay,
all
so
the
is it like then when you go to one of these private clinics, you don't pay for the basic service because it's insured, but then you pay for all the bells and whistles, so to speak? Like, is that
Yes, that's
okay?
correct. So now the government put in place and said, well, how do we keep people who want the basic stuff from being thrown to the back of the list for the people who want the bells and whistles, where these docs are going to make a lot of money and all these clinics are going to do their thing. So a provision in this bill is that you are not allowed to refuse anybody that wants just the basic, uh, OHIP insured cataract surgery or knee replacement. Now,
Okay.
how are they going to monitor that? So that becomes the question. So there is oversight and there is monitoring out of these, facilities, at least in the bill that just passed. There is an oversight. So there are going to be looking at, are you refusing these people? Are you putting them on backward, like on the back of the list? So this comes, actually, you brought up a great question. It brings you to the second point, which is how is this going to help the list at all anyway? How do we assure people are still going to get care in this private system? Well, if it's being covered, by the way, and there's a bunch of bursaries and grants, and these facilities are being paid for by the government too. So it's not, in certain ways, it's not fully private like we think. Like, here's the private clinic that you're going to pay for your
Yeah, it
regular
doesn't sound like that
insured
at all. I'm
service.
glad you cleared that
It's
up.
Yeah, it's not. So your OHIP is still going to cover the basics of these things. It's just in a private clinic that's allowed to make money off it. So like a family doc who
But
does fee for
just give us
service.
maybe one like example. So like say like someone does go for hip surgery in one of these private clinics, like you said, hip surgery is covered from in the public system, so it's going to be covered in the private system. But then what is it like? It's like they just get a better bed, they get like a better room, a private room, like hospital stay, like more one-on-one nursing, like
A
as
better
opposed to
knee,
four-on-one
instead of
nursing.
like titanium, like basic titanium, you get like titanium plus. I don't know. Like, well, cataracts, for example, you can get a basic lens or you can get a complicated lens, right? With
Okay.
cataracts. So like, the basic thing is covered by OHIP, which is what everybody gets now. But there are better, there's better equipment. There's better, like, hey, you want the robot or you don't want the robot,
Okay. So
and
basically, in the private clinics, if they do a hip surgery, they may put in like more sophisticated hardware. Is
that's
that
right.
right?
That's
Okay.
not covered right now by the insurance company.
Okay.
And the
Understood.
insurance company in this case is OHIP. That exists already. People don't recognize that. OHIP only covers, as you know, there's third-party billing for a whole lot of different things,
Yeah.
right? So, and OHIP only covers specific type of equipment. When even in the hospital, when we do surgeries, and we do all these, well, OHIP doesn't cover that. OHIP covers this. If you look at OHIP as an insurance company, plain and simple, it starts to make more sense, right? So right now they only cover certain things. You want enhanced certain things, then you
Yeah.
got to pay for it. You want the regular certain things, you don't have to pay for it. The question is, where do you have it done? Do you have it done in a private clinic where they're making a lot of money? or do you have it done in a hospital setting? Hospitals are not allowed to be these private clinics. Hospitals that already exist can't apply. It has to be independent other companies that
So
don't. Yeah.
So that being said, like, do you think this is really going to change healthcare much in Canada? Because it sounds like it's like, I mean, it may make some type of difference, but overall, it doesn't seem like it's going to be like this drastic big change that I think a lot of people understood it as.
Well, currently the only place to get, an actual knee replacement in Ontario is in a hospital where these lists go on and on and on. So the question is, so uh, will it decrease? I think the reasoning for why it won't decrease the wait list is going to be a lot different than the questions that we're asking currently. The question is it worth it for the physicians to go to these systems and build
Yeah.
these robust clinics that they're just going to have to build OHIP for? And as we know, OHIP doesn't really cover much anyways, and how many people are going to actually be willing to pay for the upgrade, So
Yeah.
we have places like Shouldice that exist, and I think that's the example that I like to use because it's covered. Your hernia is covered, but your 3 day stay is not, right? So
Yeah.
but paying an extra $500 or $600, is that going to make a difference to the system? I don't really know the answer to that. To me, it would be like, here's an urgent care, you have to pay $30 or $10. If you're a CTAS 4 or 5, pay $10. We'll probably do more for the for decreasing wait times in an emergency department than these centers, and these centers are going to take forever to roll out too. So I don't know if it's really going to make all that much of a difference.
Yeah. I mean, it sounds like it's going to be a very slow roll, like you said, and there's a lot of, red tape, which rightfully so does kind of protect the public system in a bit with, they have to justify, what they're doing and how it's not going to take away from the public system. So I can't see this being like a major overhaul in any way, shape, or form at all, like based upon what we're saying today.
It's a step towards a direction that allows for a two-tiered system.
Yeah.
It's still a one-tiered system with private clinics. That's basically what it is. Now, with third-party billing, like the same way we have OHIP currently, there are some services that are covered and some services that are not covered. In the
Like one
integrate,
thing that I know that got taken out for family docs is when I was doing my residency, ear syringing was covered, and I don't know when it was taken out. I think it was close to, it might have even been close to 10 years ago now, or something like that, 5 10 years ago. But now it's, yeah, you have to pay for that service.
right. So I refuse to do ear syringing in the emergency department. I get patients that come to the emerge. They, can you syringe my ear?
That's
Literally. And I
insane.
say, go to your family doctor. What are you doing here at 3 o'clock in the morning for an ear syringe? I can't hear very well. Okay, well, this is not an emergency. Go.
Yeah,
I
for
mean, I say
things
it
like
very
that,
kindly, like
that's where
it's
it's almost
nuts.
like we need like a walk-in clinic, almost like attached to all the hospitals or something like that, like some type of,
Some of them
you
do.
know,
There's an urgent care in like Brampton, for example. They have an urgent care that's attached to their hospital that closes at 7. We have in Hamilton, we have an urgent care, but they close and then they get super busy, but nobody go. And then walking clinics sometimes are open, sometimes aren't.
yeah,
I like the idea of having a private system or having a secondary parallel, call it a parallel system that allows for profit. The problem is, where's the for profit? Building these centers, building an OR is expensive, man. And hospitals don't make a ton of money off of these. Building a room is $1 million, more than $1 million to build one room. You know, a couple $1 million, and then you got so you've got guys, for example, already do it in plastic surgery. Plastic surgery is one of those centers, already has been in existence forever.
yeah,
It's a private system. You pay because OHIP doesn't cover it. It's
yeah.
just the adding of services like that. There are things that are covered when you go to a plastic surgeon that are covered by OHIP. If you need
Your blood work obviously is going to be covered,
your
your
pant,
basic blood
like,
work.
yeah, if you've lost 100 pounds, your first penectomy is covered, or a breast reduction for back pain or whatever, that's covered. After that, it's not. So this is just an extension of things that already exist in our society, in our
Okay.
medical system.
Well, That was a good discussion on public health versus private healthcare and summarizing what Doug Ford's doing in Ontario. So thanks for that. But the other subject that I wanted to chat with you about today was safe supply, because I know that's been a big issue that's come up lately, and it's something that I haven't really formed a set opinion on. I'm sort of still thinking about it. I am kind of leaning towards yes on the safe supply, and that may I understand both sides, because I do believe that if you make something harder to get, you know you do probably have a less risk of addiction overall when you make something very hard to get. But at the same time too, people are going to find it, and when they do find it, they're more likely to use something that's laced with a bad drug. And there was a study done, I tweeted out yesterday on my Twitter, that indicated that in Ontario, I actually was really surprised at this. In Ontario in 2020, they said that 87% of the opioid related deaths were related to contaminated fentanyl. So it's like, that still means that 13% of opioid related deaths may have been related to, just patients taking their drugs as they should, or maybe some kind of medication error in some way. But 87%, I mean, you're almost talking about 9 out of 10 people who succumbed to or died from opioid overdoses wasn't actually from the opioid that they thought they were taking. It was from something that was contaminated with fentanyl. So that's a pretty dramatic figure. Obviously, we need to do more research and figure this out. But, what do you think of the safe supply solution and what's going on in Vancouver?
So this is a topic very near and dear to me. I've been working on it for like over a decade now. It's one of the major reasons I got into cannabis, so I could do, it's like the study that I did, cannabis for opioid substitution survey, like that I worked on a couple years ago with it. Haven't published the data on it, but I've presented it a bunch of times. First of all, we have, and I'm also as a coroner, I see it all the time. You always know when there's like a dealer in town that's selling shit drugs to people, because that's when you'll see clusters of death in the same
Mhm.
night. You see it all the time. And uh, I would say, 1 out of every 3 deaths I was seeing as a coroner was an opioid related overdose for the last couple of years. We actually have some really good statistics on it. It's not just we need more studies. We have the studies. We know in other countries. I'm actually going to disagree with you on something, that the harder you make it to get, the less addiction you have. It's the opposite. We know that hardline addiction rates have decreased in countries that have more lenient drug laws. So like if you look at Portugal and Netherlands that have been doing this forever, and their hardline drug use, you can say in any society, is around 4%, and it decreased to like 2%. And crime rates drop, because where do people have to go when they can't get it? They have to go to these shady fucking places. And it's the same thing that happened with cannabis, initially, right? People that, when drug laws are harder on cannabis, you have higher hardline drug use, because these
True.
cannabis guys have to go to these places, right? So um, we have really good statistics on it. The problem is Ontario. Ontario has the highest rate of opioid addiction in the world, and
Is
it's
that true?
they've
That's
yeah,
crazy.
yeah, and in particular, and Hamilton runs higher with death rates than the rest of Ontario. So technically, Hamilton is the world's leading uh, opioid addiction city of the world. It's
That's
crazy
crazy.
per capita, of course,
London's
because
got to be up there too. And London,
per capita.
unfortunately, was named Canada's least happiest city. I don't know if you
Hooray!
saw that the other day.
I didn't
But
see it.
but
Amazing,
anyways, let's stay on
amazing.
topic because we only
Yeah,
had
so
so much time left.
you can look at this stuff online. Actually, Hamilton has a very good opioid tracking system. Now we look at deaths, we look at death rates and all this stuff. It's right on the website in Hamilton. Just write Hamilton opioids and it'll show up for you. Yeah, and BC. Don't get me wrong, BC does a very good job of leading the country in death. We do a good job of leading our country and potentially the world in addiction. And so the question then becomes, is our goal to decrease addiction rates or decrease death rates? Right? These are questions we have to ask ourselves. Because we know safe supply will decrease the death rate. certainly. It's inevitable. Most of these people that die are accidental overdoses. The,
Is it like that the is will it decrease the death rate in the long term but not the short term? And I'm just saying that because I thought that in Vancouver recently when they did come out with safe supply, there was like the worst month in opioid related deaths.
so it all depends on where you get it. Like, not where you get it. Sorry, how accepted it is, right? So if
Okay.
it's still not accepted in BC, they have one center that has the ability to that is illegally, however you look at it, selling non-laced drugs, right?
Yeah.
And still they don't have, and all they're doing is selling the drugs. They're not trying to actually help people off the drugs. And excuse me, that's where I differ from just the idea of having safe supply. If you're going to have safe supply, you have to have a therapy associated with it. So I'm not against safe supply. I'm not against decreasing our death rate. You just said 87% of these things of deaths related to opioids are because of bad drugs,
That
bad,
was,
laced.
yeah, Ontario 2020 data. Yeah.
Yeah, but well, that's the most updated data we have. I think we have 2021 now, maybe. But I'm telling you, as a coroner, they're all accidental deaths. These aren't
Yeah.
people trying to kill themselves or taking too much. Most of the time, they're taking their usual amount, whatever it is, and dying because of shitty fentanyl. When it comes to opioid problems. So, do I think safe supply will help? Absolutely. Do I think that's where we should go? Yes, but we can't go there unless we have a robust system that's willing to offer mandatory therapy for anybody that accesses this system if the government is funding it. Currently in Hamilton, we still have one place that has a safe consumption site, downtown Hamilton. The problem is you look at it, it's just a bunch of booths that you go to and they say, you're going to have access to therapy. We're going to give you this stuff, but it's not a robust system. It's not an accepted system. We have to create a system that allows people to get, or provides people, not allows, provides people the opportunity to get therapy. And even if it's mandatory, if they want to access the system, if the government is going to be paying for it, if the taxpayer is going to be paying for it, because yes, we want to decrease the death rate from this, but at the same time we have to get to the underlying reason why people have an addiction. And I deal with a lot of addiction, both in the emergency department. We did in our clinics for a very long time, as I'm sure you do, and nobody wants to be an addict. You ask when you're an addict, it's really tough and you'll do anything to get your drugs, but nobody started off their life saying, I'm going to be an addict, right?
100%.
These people, a lot, I know I say these people, they're us. And there's a lot of people like us that have addiction issues. They don't want to be there, but it's very, very, very difficult to get out of. It's so difficult to get out of. And
And
a lot of times
the
they
other
die.
part
So
of
we
that
have to
too is
provide
that
them the
like
opportunity.
if you do get out of it, like and you're still have like a bad life, like you're not doing well financially, you don't have a job, maybe you don't have too many friends or family around, like you can just fall right back into it. So like sometimes when you fix the
Yeah.
addiction, you don't really fix the underlying issue, which is it could be just like a bad life, like a sad person, like maybe they do have some mental health problems that do need to be resolved. I think that like you said, I agree with you with regards to like the safe supply and the treatment.
Has
Obviously
to be
that's,
integrated.
yeah, like obviously that's like probably going to be a very expensive and costly way to go, but it also seems to be the most data driven place to go as well. So
So sometimes, if you have a concern for society and we want we have a vested interest in the progression of society. Otherwise, we don't have, currently we have a breakdown of pretty much every aspect of fucking society in our world. But some of us have to have a vested interest in the ongoing progression of humans.
yeah.
And to do that, we can't just think um, you know, about one aspect. It's got to be an integrated system if we're going to progress and care about those who come after us or those who are with us now. We can't just provide them the opportunity to do their drugs. So yeah, we decrease the death rate, but we don't fix the problem. If we have to get to the bottom of the problem, is why are you addicted in the first place? And I'm going to say it's not just a little bit of mental health, it's over 75% mental health, and addiction falls into that. Addiction falls into that category. So and a lot of these people started because physicians started them on fucking pills.
Opioids. Yeah.
And as you pointed out yesterday on your social media, it's the third leading cause of death
Yeah.
is prescription drugs,
And
right? So
half of those people were taking their drugs correctly, right? So
oh yeah,
it's not like half, it's not like, it's all people just like abusing their drugs. I mean, that's, a small percentage of it for sure, but it's people actually taking their drugs correctly,
yeah. And I
which
do
is kind
think
of the scary part.
it is. I do think we have the ability to bring governments together, even the ones we don't like, with, one government wants to just give everybody drugs. The other government wants to put everybody in jail. And the middle path is, how do we provide a safe environment for people who have addiction without throwing them in jail?
Well,
And
what I was going to ask you was like, what does it look like? Like when you say, we should provide, and I agree with you 100%, like we should provide the safe supply, but we should also, provide the counseling and everything that goes along with it. Like, what does that really look like? Like someone, is in need of their fix. So they go to, the safe supply center, they get their safe supply. So they know that, their medicine or, their whatever we're calling it is going to alleviate whatever is going on, but at the same time, how does that help that person if we don't provide some type of counseling? So like,
right.
do you give them like a card? Do they have to go straight to a center? Do they have to go sign up for some meeting like an AA, for
Yeah.
example? How do you see that sort of working?
Well, obviously, it's going to be a work in progress till we get it to the point where it needs to be. But I know you go to any casino, and they have Gamblers Anonymous at the front door, right? Every casino has to have a therapy location on site at pretty much. And in Ontario, if you go, they all have AA. You go to Niagara, they have AA, or not AA. They have Gamblers Anonymous right there.
Yeah.
So these
Well,
centers
we don't have Alcoholics Anonymous at
at the LCB.
LCBOs,
I
but
get that. Yeah,
yeah,
no, which would be a great idea if we
yeah,
did. But society is only willing to ever accept like two illegal things to do at any given time. So we have gambling and alcohol. We have a third one now, which is cannabis. But that's how societies basically in general work. So the question is, how should we work these things? It's a good question. People aren't going to be able to, hey, here's your fix, go to therapy. No, you're going to have to, like, whether it's once a week, hey, you've signed up. If you show up, excellent, you're still in the program. If you don't show up, you're not in the program. We did that with cannabis. I did that. You got to show up to your 3-month appointments. We got to talk
yeah.
about all these things. I did therapy basically with my patients every 3 months, if they wanted to continue their cannabis. And work themselves off their narcotics or whatever it was. They had always had to be working towards a decrease in narcotics to stay on the cannabis. That was like part of the thing. Now you could create these robust systems with therapists and group therapy, which I think works very well. Which is, it's always good to have people who are understand what you're going through in similar
AA
situations.
has very, very good
Yeah,
rates of people having success, like
that's
very,
right. So
very
you
good
need something
rates.
like that where these people have to, I keep saying these people, but it's people like us. I don't mean it in that way.
We
So,
we know what you mean. That's
all
okay.
right. So, where you show up and you could do your safe injection or safe consumption, whatever it is, but you have to agree to come to therapy once, twice a week. And if you don't show up and you miss, the same way you get caries with methadone, you show up, if your pee's clean, you get to take your caries home. If you don't, then you lose your caries. Or you get thrown
Yeah.
out of the program. Same kind of idea. Why don't we do something like that?
Yeah, I think I could see, that being definitely a solution because, like you said, we already do it with methadone right now. Like, people, get the carries, they don't get their carries, when they, mess up, then, the carries are eliminated. So they have to come in every day, they have to take it in front of the pharmacist, that kind of thing. So
Right.
yeah, I think there are ways where, we're already using this system to some degree. We could just, make it expand it a little bit and just improve on it. We can improve on it with, obviously offering the safe supply, and then we can improve on it by, having something attached to the safe supply. Like I like your idea of like, okay, like we're going to give you your safe supply of the drug that you need to, alleviate your withdrawal symptoms, but we're also going to be giving you some type of card or some type of service right on the spot to help alleviate your addiction issue.
Yeah.
And maybe that's, the best solution. And, and I'm not saying even that like with that solution, we're going to eliminate drug problems or substance abuse problems. Like everyone has to understand that, whatever solution that we come up with is just going to be a little bit better than, what we have now. Like the
That's right.
unfortunate truth is that like, there's no perfect solution. People have suffered, ever since, there's been humans. And unfortunately, when people suffer, they, use drugs. And so all we can really do is just try to minimize that. But I think the strategies that we've discussed today are ways that we can potentially, eliminate or reduce a lot of the deaths. Again, I'm kind of still shocked at that like 87% number in Ontario in 2020. Again, it's almost
I
9 out
believe
of
it.
10 people, right? It's
I believe
crazy.
it. Yeah, I
Yeah,
believe it.
it's a lot, 9 out of 10.
Yeah, that's it's pretty huge. Listen, we see it all the time as the coroner. It just is what it is. Like, there's got to be a way that we can provide people with a safe, like a safe supply, but at the same time try to help the underlying cause. I'm
Yeah,
not a prohibitionist in any way. I think making any drug illegal is weird. I don't think drugs fall under law. They fall under mental health
yeah,
and medicine. And making any of them illegal is really just a way to make money and put people in prison, which we've seen happen and break down society. Society will correct itself, like in most things. Yeah, maybe laws. Obviously, we have laws in place. Don't murder, don't steal, don't do those things. Yeah, we need that. But when it comes to things like drugs, you either gonna like society like will survival of the fittest a lot of the times. If you put people in positions of to make their own decision, if they make the bad decision, they'll learn from that mistake and they're not going to do that mistake again for the
yeah.
most part, right? I don't like to call myself a prohibitionist at all. I don't think we should make drugs illegal. What we should do is promote wellness, and if we promote wellness, we'll have a less problem with addiction.
I agree. So we're almost out of time there, Ira.
All right.
Any closing thoughts?
I think there's a lot of room for improvement here in Canada and Ontario in particular, and hopefully we get there, man.
Yeah, I hope so too. Well,
It's always
thank
a
you.
blast chatting with you.
Yeah, man. It's great chatting with you today. I'm really happy we got through both of those subjects. I'm sure we'll be chatting about them again soon. Tell people where they can find you again on your Instagram and your Twitter and all that kind of stuff.
So I actually spend most of my time on Instagram or TikTok.
Nice.
Mostly on Instagram. Dr. Ira Price on both of them.
Awesome. Okay,
Yeah.
brother. Well, thank you so
All right,
much
man.
again for coming on. Thank you so much,
Thank
everyone, for
you.
listening. And I'll be back again soon.